interesting session of Quest program. Today we have a very informative talk by Dr. Jino, followed by the viewing of the film The Hope Circle. So may I request dear Thomas Achan, our chaplain, to lead us in prayer.
നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം, പ്രാർത്ഥിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധഹായ്ക്കും സ്തുതി, ആദ്യമേക്കും തന്നെ ആമേൻ. സ്വർഗസ്ഥ പിതാവാൻ ദൈവമേ, ഫെബ്രുവരി മാസത്തിലെ രണ്ടാമത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി സ്തോത്രം അർപ്പിക്കുന്നു. വീണ്ടും പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ പഠിക്കുവാൻ ഞങ്ങൾ വന്നിരിക്കുന്നു. ഇന്നത് ലീഡ് ചെയ്യുന്നതായിട്ടുള്ള ഡോക്ടർ ജിനോ സെബാസ്റ്റിനെ ഓർക്കുന്നു. ദൈവത്തിൻ്റെ സാന്നിധ്യം തന്നോടുകൂടി ഉണ്ടായിരിക്കണമേ. ഞങ്ങൾ കേൾക്കുന്ന കാര്യങ്ങൾ ഞങ്ങളുടെ ഹോസ്പിറ്റലിനും മുൻപോട്ടുള്ള ഞങ്ങളുടെ പ്രയാണത്തിലും അത് ഞങ്ങൾക്ക് അനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമേ. വന്നിരിക്കുന്ന ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി സ്തോത്രം, യേശു ക്രിസ്തുവിൻ്റെ വലിയൊരു നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
This quest is a special edition of the World Cancer Day. Dr. Jino is well known to us. In a short span of time, he has well established the division of onco-surgery and performed many complex surgeries successfully. I invite Dr. Jino to lead the session.
Good morning, everyone. Today's topic is the management of early breast cancer and why it is so serious. And this is the roadmap to my presentation. Initially, I will shortly describe what is early breast cancer and why it is considered so serious, and briefly through the management of early breast cancer, and coming into a conclusion. Before coming to what the definition of the early breast cancer, let us see what is breast cancer now. So in the last 2 decades, the definition of actually the entire definition of the breast cancer has actually changed a lot, and the definition of what breast cancer is it has changed in such a manner that it has changed a lot, and compared to the knowledge that we had previously, the knowledge we know now about breast cancer is actually in a revolutionized magnitude. So it is a group of disease with different molecular characteristics identified by various molecular tests like gene expression profiling, IHC, proteomics, and next generation sequencing, etc. And it has different prognosis and pattern of recurrences and dissemination after multidisciplinary treatments, and have different sensitivities to available treatment. So it is actually a spectrum of disease, and with different sensitivities to different available treatments now. And let's come to what is early breast cancer. And the understanding that we have now about breast cancer has now reflected in the 8th edition of the AJCC staging, and it has included grade, the estrogen receptor status, progesterone receptor status, and HER2 status also in the staging, not only the TNM status as usually we see in most of the other cancers. So cancer staging of breast cancer staging is now extremely complex when compared to the other cancers, and it is now not anymore TNM staging. It is TNM plus the biology of the breast cancer is also included in the cancer staging. And so this staging is actually what the present staging, the AJCC 8th staging of breast cancer is actually a very complex staging, and we cannot actually remember that staging by any human being. So previously we used to say T1, T2, N0, N1, M0 was considered as the early breast cancer. But now the biology of the tumor, that is the estrogen, the hormone receptor status, the HER2 status, and the grade, which is collectively what we call as biology, has seriously taken over the TNM status of the tumor, and the staging is completely now ruled by the biology of the tumor. So, as we previously say, the early stage of the tumor, as we know, we usually say, usually mention about the early stage as the stage that we can treat and cure completely. But now it has changed a lot, and the biology of the tumor is now considered in the staging as, so what we call as early breast cancer is the stage at which the biology with which the tumor responds to the treatment. That is the way we see the breast cancer now. How the tumor responds to the treatment, and that is considered as the stage of the disease. I will explain it in the further slides. To start with, the breast cancer, the biology, the behavior of the breast cancer was tried to explain in different theories, starting from in the 1800s. In 1894, initially the famous surgeon Halsted proposed his theory known as Halstedian theory, and he proposed that breast cancer spreads stage by stage, step by step. That is, from breast it will initially spread to the axilla, then only it will spread to the distant sides. That was the initial concept of breast cancer metastasis, and that concept actually prevailed for a century. And after in 1980, Dr. Fisher proposed the systemic theory. That is, he proposed that breast cancer, in the initial stage itself, it is a systemic disease. It is to be considered as a systemic disease, and it will spread to the distant sides in the initial stage itself. That was the theory he proposed. And later, in 1990s, Dr. Hellman proposed the currently most accepted theory, that is the spectrum theory. That is, breast cancer, according to the biology of the tumor, it can spread. In some of the tumors may spread to the distant sides initially itself. Some of the tumors may not spread. Some of the tumor may be in the local regional area. Some of the tumors may spread distant sides also. So it is to be considered as a spectrum. That is the most recent concept of breast cancer. So as we think about breast cancer, early breast cancers also maybe according to its biology, it may spread to different sites. So if the tumor is having a bad biology, we may have to consider the tumor is already metastatic. That is the idea behind that. So this much amount of understanding led to this amount of changes in the treatment pattern. That is, the surgery which was proposed by Halsted was a radical mastectomy, and his idea was to remove the entire breast and the chest wall muscles and the entire axilla. And the understanding that we have led to the limiting of the surgery, the area of the surgery, that is, the radical mastectomy has now become, breast conservation surgery has now become standard of surgery, and the extent of axilla clearance has also come down to sentinel lymph node biopsy, and improved safety of RT and improved delivery of RT has changed the side effect pattern of the radiotherapy. And adjuvant systemic therapy has revolutionized, and pre-op systemic therapy has come into role, and different targeted therapies like endocrine therapy and immuno-oncology came into existence because of the knowledge that we have now about breast cancer. So why is it so serious? And we all know how Joker has asked that question in the Batman movie. And that is the same question that we are asking now. Why it is so serious about breast cancer? It is the same thing. That is, the knowledge about biology has become so important for managing the breast cancer. And this biology of the tumor has divided the breast cancer mainly into three types. That is, hormone receptor positive types, and HER2 receptor positive types, and triple negative breast cancers. And although TNM is not so useful in our area, where we readily have the access to hormone receptor and HER2 receptor status, some of the areas in the world where the HER2 status and the hormone receptor status is still not easily available, TNM status is still useful for staging the breast cancer. And biology-based staging is actually giving a better prognostication of the treatment, better prognostication of the patient, and a better treatment selection. And biology has also helps us to predict the benefit from systemic therapy. And with stage may be different. The stage actually may be different. That is, this is the main point that I want to highlight. According to the biology of the tumor, when it is compared to the previous TNM staging, the stage of the patient may be a lower stage, but it actually reflects the prognosis of the patient by how the patient responds to the treatment. Okay, this is the cancer burden that is shown in Globocan 2022. Both sexes combined, female breast cancer comes as the second most common breast cancer after lung cancer. Actually, in Globocan 2020, breast cancer was the first, the most common cancer, but in 2022, it has updated as the second most common cancer, both sexes combined. And it comes as the fourth most common cancer causing mortality among all the cancers. And coming to managing of the early breast cancer, we all know that the management starts by examining the patient and taking proper history, and then doing a bilateral mammogram and ultrasound of the both breast and regional lymph nodes. And the next step is doing a core biopsy, and after the core biopsy, the diagnosis is confirmed. In still some areas, some part of the even in our state, in some part of in our state also, an excision biopsy is considered. Why not so serious is the question. We have to become serious when it is when the diagnosis is diagnosis can be a breast cancer. The thought has to be more serious, because many time many physicians or many surgeons who are managing breast cancer will consider doing an excision biopsy, and many times maybe the margins may be negative, but the axilla remains untouched. So whenever the diagnosis is considered as a breast cancer, whenever the treatment is being considered for breast cancer, the treatment is not only for the breast, we have to consider the axilla also. So many times after the excision biopsy, when the diagnosis is confirmed, the patient has to undergo another surgery for the axilla staging. So always go for a core biopsy for the diagnosis. When the core biopsy is not available, when the frozen section is available, it has to be utilized for the diagnosis. When the frozen section is available, and if the frozen section comes as positive, then in the same setting we can go for a axilla staging also. So after the biopsy, when the diagnosis is confirmed, the ERP or HER2 status has to be done. And even if it is an early stage disease, if it comes as a bad biology disease, the patient will go for a neoadjuvant treatment. That is the present guideline of treatment. So after the diagnosis, the second stage of the treatment is always staging. And if it is in a locally advanced stage, you have to go for a staging procedure, staging imaging like CT scan and bone scan. either CT scan plus bone scan or doing a PET scan. If, especially when the patient is having some kind of symptoms that is suggestive of metastasis. Even if there is no symptoms of metastasis, if the biology of the tumor is very bad, then we have to consider doing a metastatic evaluation, even when the patient is not having any symptoms. And when the stage is also determined, when we are planning for a breast conservation surgery after a neoadjuvant treatment, the tumor has to be marked for planning a breast conservation surgery. So that is the treatment algorithm. And I will go straight towards the first usual management of the most common type of early breast cancer. That is, most common type of early breast cancer is a good biology tumor. That is hormone receptor positive and HER2 negative status. These tumors, usually if it presents as early breast cancer, the primary treatment will be usually surgery. So surgery is usually breast conservation surgery. Breast conservation surgery is a term that is a broad term which can include wide excision, plus axillary clearance, bar sentinel lymph node biopsy, and oncoplasty. So why an oncoplasty is added into that breast conservation surgery? Why is it so important? It is not only for a better cosmesis. So many people may think that it is only for a better cosmesis. Better cosmesis is not only the primary aim of an oncoplasty. We know that we already know that after breast conservation surgery, patient will eventually go for adjuvant radiation therapy and adjuvant chemotherapy. It is a multimodality treatment. So patient has to recover from the surgery early and go for the adjuvant treatment. That is the primary aim of the surgeon, to send the patient for the adjuvant treatment. The surgeon should know that surgery is not only the treatment, and the entire treatment comes as a package. So after surgery, the patient should recover very soon from the surgery, and the wound should heal fast enough so that the adjuvant treatment can be started early, so that there is no chance for there is maximum chance for cure and less chance for recurrence. And surgery is not a silly job, and it is a serious job. So if the post NACT, that is post neoadjuvant treatment breast conservation surgery is planned, the tumor has to be clipped or tattooed for marking the tumor. We have to know where the tumor is. Many times, if the tumor biology is bad, after the neoadjuvant treatment, the entire tumor will disappear. So we have to mark the tumor to know where to do surgery. Even if it is a clinically complete response, surgery cannot be avoided. Many patients will come and ask, sir, if there is no tumor now, can I avoid surgery? Avoiding surgery cannot become a part of a curative treatment. It is not a standard treatment till now. So we have to do surgery anyway, even if the post neoadjuvant treatment mammogram is showing complete response, we have to do surgery. So before the treatment, before the systemic treatment itself, we have to mark the tumor either by clipping or by doing a tattoo. And after surgery, the specimen has to be tagged properly so that the pathologist can identify the margins. And negative margins has to be achieved for the invasive carcinoma. If it is only a ductal carcinoma in situ, negative margin is not enough. 2 millimeter, either at least a 2 millimeter margin is needed. And after a breast conservation wide excision, the base of the tumor has to be clipped for a boost of RT along with the wall breast RT. Okay. And after the breast surgery, coming to the axilla surgery, this is a crowded slide, but a lot of information I have included in this. SLNB is the standard procedure for early breast cancer for the axilla, and an isolated axilla recurrence after an SLNB, even within 5 to 10% false negative rate is less than 1%. So SLNB is the standard procedure. If we detect a micrometastasis in SLNB, axillary clearance is not indicated. And studies have shown that T1, T2, in T1, T2 cancers, if the patient is undergoing breast conservation surgery with 1 or 2 nodes, sentinel lymph nodes positive, actually we can avoid axillary clearance if the patient is undergoing radiotherapy and systemic therapy. And this is shown by ACOSOG C11 trial. And axilla RT. If patient is undergoing, if the patient is undergoing SLNB and if SLNB is positive, even patient can undergo axillary RT and avoid axilla surgery. So axilla surgery can even be avoided even with sentinel lymph node biopsy positive. If the patient, if we are doing a sentinel lymph node biopsy post chemotherapy, in the post chemotherapy only in N1 patients, that is 1 or 2 or 3 nodes positive patients post chemotherapy, we will do an SLNB. We can do SLNB even after doing post chemotherapy. So for doing an SLNB post chemotherapy, we need a dual tracer. That is, 2 dyes has to be injected. One is a blue dye, and the second dye has to be either an technetium 99 or ICG. We don't have the second dye here, and so post chemotherapy SLNB we are not doing. Only pre-chemotherapy SLNB we can do with a single dye. Post chemotherapy SLNB we are not doing because dual tracer is not available in our setup. Either we need an ICG or a technetium 99. And if the node is marked pre-chemotherapy, then the false negative rate of SLNB after chemotherapy is similar to a targeted axillary dissection. Targeted axillary dissection is a marked lymph node biopsy plus SLNB. Marked lymph node biopsy is before chemotherapy, we have to mark the lymph node and we have to take out that lymph node along with doing a sentinel lymph node biopsy. This is the targeted axillary dissection. And the false negative rate of a post chemotherapy SLNB can be similar to targeted axillary dissection if we are following these things. I know that I am rushing through, and these are actually some minimum things I am saying about the axilla surgery, and these are the trials that supports these evidences. Okay. So these are some pictures of the procedures we have done. We means me and Dr. Anish have combined, and if I have been shown some pictures in this presentation, it will be actually shame for me. So this is the tattooing of the tumor. Before chemotherapy, the tattooing was done. And after chemotherapy, usually there will not be any lesions palpable if the tumor is having a bad biology. If the tumor is having a triple negative biology, entire tumor will usually disappear. That is known as clinical complete response. Clinical complete response we can expect in a bad biology tumor. But if it is an hormone receptor positive tumor, a complete clinical response cannot be expected. Many times there will be a tumor remaining even after chemotherapy. That is actually a paradox. If the patient is having a good biology, patient will respond minimally to the preoperative systemic therapy. If the patient is having a bad biology, the response to chemotherapy will be better. And this is the wiring we do. Rarely we do. Instead of doing this tattooing, if the lesion is very small and if the lesion is very deep in the breast, and if we suspect that post chemotherapy there may be a lesion inside the breast that we may miss during surgery, we will insert a clip before chemotherapy, and after chemotherapy we will do an ultrasound and locate the clip inside the breast, and we will insert a guide wire into that clip, and we will take out the wire and clip along during surgery, and we have to do a specimen mammogram to detect whether the clip is inside the tumor or not. And then we will send the specimen to the pathologist to look for any residual disease and margin. These are a few pictures showing some of the procedures. This is a bat wing oncoplasty, and this is an Grissotti oncoplasty done for a central quadrant tumor. And this is a LICAP flap, that is lateral intercostal artery perforator flap, deepithelialized and completely inserted inside the breast. And this is an racket mammoplasty. This is an skin sparing mastectomy done with de-epithelialized LD flap, the latissimus dorsi flap. Okay. Now coming to radiotherapy in early breast cancer. So after breast conservation surgery, radiotherapy is a must. So radiotherapy cannot be avoided within breast conservation surgery. So if the patient is having any kind of contraindication for an radiotherapy, breast conservation surgery is also contraindicated. So after breast conservation surgery, patient will undergo wall breast RT. That is usually 50 gray and 50 gray 15 fractions. And this has proven, many studies have proven that post surgery wall breast RT will reduce 10-year recurrence risk by 15%, and there is a 4% reduction in 5-year breast cancer related mortality. And along with the wall breast RT, regional nodal irradiation is also sometimes given. And recent studies have shown that 50 gray 15 fractions is equivalent to 27 gray 5 fractions. So patient can go home after taking 5 fractions of radiation. So by 5 days of radiation, the entire radiotherapy will be completed. And RT may be avoided in old age patients with a ER positive tumor, that is hormone receptor positive tumor, and a node negative tumor, and taking aromatase inhibitors. So all factors has to be there for considering avoiding RT, explaining to the patient that there is a higher chance of in-breast tumor recurrence if the RT is avoided, even in these patients. So whenever the patient is old age and having multiple comorbidities with all these good biology, good prognostic factors, we can consider avoiding RT even after breast conservation surgery. So coming to the systemic therapy. Systemic therapy is the field in which the breast cancer has evolved a lot, enormously, and revolutionized the entire breast cancer treatment in the last 2 decades. So previously we used to say that NACT. Now the term is actually obsolete because it is not only the chemotherapy. We have a lot of other treatments like targeted therapy, immunotherapy, and hormone therapy. All these things are systemic therapy. So it is now termed as pre-treatment, pre-operative systemic therapy. So it is actually PST, it is not NACT. So the first thing is hormone positive cancers. Hormone positive cancers, usually when the nodes are positive, when the node is positive, we will send the patient for neoadjuvant chemotherapy. If it is completely curable stage, then we will send the patient for neoadjuvant chemotherapy. And then, and as I already said, a complete pathological response is rare in case of hormone positive disease. And adjuvant endocrine therapy is standard. That is, after surgery, adjuvant endocrine therapy has to be given for at least 7 to 8 years. And there is a standard treatment for all hormone positive early breast cancers. And adjuvant chemotherapy is to be considered in almost all cases. It can be avoided according to the newer tests like Oncotype DX. Oncotype DX is a 21 gene assay especially done for early breast cancer, T1, T2, N0 and N1 patients, to know that whether they can avoid chemotherapy, whether the patients will benefit from chemotherapy. We are doing Oncotype DX test, and the Oncotype DX test is actually supported by the RxPonder and the TaylorX trials. And this is for the MBBS students. You have to know that all these trials and evidences are coming out from these randomized control trials. I have mentioned some of the names of the randomized control trials, and just for your knowledge that all these evidences of management of the malignancy we are getting from these randomized control trials. These are huge studies that are conducted by multiple centers over multiple nations, and we will randomize the patients into 2 groups, and we will see which group will benefit better. And these are the names of such trials by which through which we are arriving at these conclusions. And this is another drug, that is abemaciclib. It is for high-risk hormone-positive diseases. After surgery, if we see that patient is having residual disease and heavy residual disease in the nodes also, patient will be offered this treatment with abemaciclib. That is a CDK4/6 inhibitor, and that is by Monarch trial. And what if it is a HER2 positive tumor? HER2 positive tumor, only T1 tumors, T1 N0 tumors will go for a primary surgery. That is, T1 means less than 2 centimeter. Even if the tumor is more than 2 centimeter, and even if the tumor is N0, patient will go for a neoadjuvant treatment. That is neoadjuvant treatment with chemotherapy along with Herceptin, that is trastuzumab. Pertuzumab is another similar molecule that can be added along with the neoadjuvant treatment. And if there is, usually there will be complete response for HER2 positive diseases. After chemotherapy, if the patient is having a residual disease during surgery, after surgery, when we see the specimen, when we see the pathology report, if the patient is having a residual disease, that is considered as a poor prognostic factor. That is, even when the patient is having a residual disease in the node or in the breast, when the patient is having HER2 positive disease, that is considered as a poor prognostic factor, and patient has to continue treatment with a TDM1. That is another molecule. That drug has to be given for patients who are having a residual disease. And coming to last few slides, that is TNBC, that is triple negative breast cancer. If the patient is having a triple negative breast cancer, even patient is having T1C, that is T1C is 1 to 2 centimeter tumors. Even when the tumor is more than 1 centimeter, patient will go for neoadjuvant chemotherapy. Even such a small tumor will have to go for a neoadjuvant treatment. Patient cannot undergo a primary surgery. That is the current guideline for treatment. And what is the benefit of giving a neoadjuvant treatment in such a small, even in such a small tumor, is that we can know an in vivo response of the tumor to the chemotherapy. If we are doing the surgery first, and we are actually removing the cancerous tumor from the body, and we cannot test whether the tumor is responding to the chemotherapy. That is the idea behind giving, that is one idea behind giving neoadjuvant treatment first in these bad biology tumors. When we are giving the chemotherapy with the tumor in the body, we can assess whether the tumor is shrinking or not. If we are doing the surgery first, actually we are removing the measurable tumor from the body. So we cannot assess whether the tumor is responding to the treatment. That is the idea behind that. So we can know the behavior of the tumor, whether it is responding to treatment or not. And if there is node positive disease, and the immunotherapy pembrolizumab can be added along with chemotherapy in neoadjuvant setup. So even in neoadjuvant setup, immunotherapy is coming up. And if there is a residual disease, post-chemotherapy, post-op, patient has to continue to around 6 months treatment with the capecitabine. And if the patient is a BRCA mutant patient, then patient has to offer an olaparib also. So I have actually rushed through the management, and in the last 2 slides, I have summed up the entire treatment in 2 flowcharts. And all hormone receptor positive patients has to undergo endocrine therapy. Adjuvant endocrine therapy has to be given, and adjuvant bisphosphonates has to be also given to hormone receptor positive patients. And if the patient is hormone receptor positive, locally advanced stage, patient has to go for neoadjuvant treatment, then surgery. And if the patient has undergone an breast conservation surgery, patient has to undergo radiation therapy. And even if the patient has undergone mastectomy, if the patient is having high risk of recurrence, then will the patient go for radiation therapy. And adjuvant systemic therapy has to be continued. And in HER2 positive disease, in T1 N0, patient will go for a primary surgery and radiation therapy. and then we'll go for systemic therapy. If systemic therapy is present, then radiation therapy will follow systemic therapy. That is the usual the order of treatment. Then if the tumor is T2 or above or node positive disease, then patient has to go for neoadjuvant treatment, then surgery, and then systemic therapy and radiation therapy. Then if the patient is a TNBC, triple negative breast cancer, T1A and T1B will go for a primary surgery, then followed by adjuvant treatment. From T1C to above, the patient will go for a neoadjuvant treatment and surgery, then followed by adjuvant systemic therapy. So coming to conclusions. So what I want to stress is that the breast cancer is now considered as a spectrum of disease with different biology, different behavior. It is not a single disease. Even in this same patient, even in the same type of breast cancer, we can actually see different biology of the tumor. When we see, when we check for ERPR HER2 status in the pre-op biopsy, it may be ERPR positive. Sometimes when we repeat the same report in the post surgery specimen, sometimes it is different. So what we understand from that is that even in the same patient, in different areas, the biology of the tumor may be different. So the tumor will respond differentially to different kind of treatment, even in the same patient. So we need to understand the behavior of the disease to deliver the proper treatment and get the best outcome. And response to neoadjuvant systemic therapy can be predicted by the biology, and it can predict actually the recurrence and prognosis also. So thank you. And actually, I know that I have rushed through the treatment, and it's very difficult to cover the entire breast cancer, early breast cancer management within 20 minutes. I think I have given a small idea regarding the topic. If anybody is having any doubts, please ask. Actually, the definition of radical mastectomy is removing the breast and the chest wall muscles and the axillary clearance. So very rarely we will do radical mastectomy. That is when the patient patient is presenting with such a locally very advanced disease. Usually the patient will be metastatic. It will be a metastatic disease. In a rare case scenario, when it is not a metastatic disease, patient will usually go for a curative intent neoadjuvant systemic therapy, and we will reassess the disease how it is. Most of the time, the tumor must have reduced in size, and all those surrounding structures will be not affected. Even after neoadjuvant systemic therapy, if the tumor is affecting if it is involving these surrounding structures like the pectoralis major and minor and the chest wall, we can go for a radical mastectomy. That is the rare indication. Usually after neoadjuvant chemotherapy, the tumor will shrink, and we have to only go for an modified radical mastectomy. And chest wall involvement is actually defined as the involvement of serratus anterior and the intercostal muscles and the ribs. Even the pectoralis major and minor is not considered as a chest wall involvement. So even if we remove the pectoralis major and minor also, it is not considered as a radical mastectomy. So it is a very rarely done procedure now, radical mastectomy. Ma'am, you are asking about the metastatic evaluation. Okay. For follow-up. For follow-up, no, we usually look for local recurrence only by doing mammogram only. Yeah, MRI is indicated in a very specific indications where the patient is having very high risk of recurrence, and when the breast is very dense, No, we cannot assess the tumor, or we cannot assess the recurrence by doing a mammogram when the tumor is very when the breast is very dense, especially in very young patients. And another indication for MRI is doing for screening for BRCA positive patients with very young patients with a very dense breast. That is another indication for doing MRI. And for what you asked, post-operative follow-up, for local recurrence, we will do only mammogram usually. And whenever the patient is having any symptoms, we will do for systemic metastatic evaluation with the CT only. And if there is high suspicion of any metastatic lesion, we will go for a PET scan.
Okay, thank you.
Thank you, Dr. Jino, for taking us through the newer diagnostics and modalities of breast cancer. Now we will have the screening of the film. It's a very short film, and around 12 minutes, taking us through a journey of Varun. And let's see what lies behind the haunting smile of Varun.
Varun! Please don't.
Hello, Linda. I'm gonna take the whole day off. Something urgent has come up. Bye. Okay.
The European Union has adopted new visa rules that will allow frequent travelers from India to apply for multiple entry Schengen visas with longer validity, easing travel to 29 European countries. Nearly 66,000 Indians officially became American citizens in 2022, according to the latest
Daddy,
congressional report.
your favorite breakfast today?
Rishi Sunak's Rwanda bill finally cleared Parliament after 8 hours of debate as MPs and peers sat through the night to pass the flagship legislation. Iran's president
Eat while it's hot.
has refused to join ranks with Pakistan's Prime Minister.
Don't wait up for me. One of those long days.
What are you investigating so much? A murder mystery? We really don't have that kind of time. Hurry up.
Hi. It's okay. Don't worry.
Hi, Varun.
Hi. Mr. Verma's case is sorted.
That's great.
So, how's the policy coming along?
Miles to go before we sleep. Long way to go.
We better not sleep then. Meeting starts in 10 minutes. Bye.
We'll be there.
Thank you. Bye.
So that's Varun, the one everyone keeps talking about?
Exactly. It's his resilience that keeps the Hope Circle going. Have a look at this draft that he's prepared.
Uh-huh.
Years ago, he was one of our brightest medical students. Unfortunately, his mother fell ill. She was admitted with us with end-stage cancer. There was very little we could do. His family was struggling financially. After his mother passed away, his father fell into depression. We tried to help in so many different ways, but Varun couldn't handle the financial and emotional strain. He made the difficult decision to quit medical school to support his father.
Oh, that's so sad. I heard he's at the forefront as a volunteer for the Hope Circle. Doesn't he have an actual job?
You would love to hear this. What he did was, as he went through this struggle, he did a course in finance. And now he works in a bank.
Oh, really?
And he's doing extremely well. What he does is he tries and accesses schemes for cancer patients. He finds whether he can get funding for the treatment of patients. He's just absolutely wonderful.
That's incredible. He's truly turned his pain into purpose.
What are you investigating so much? A murder mystery?
Hi everyone, I got some food to keep you all energized. Hello everyone. Hi, come, take. At last, something healthy. Thank you so much. Sorry, Vidhan Parth. I wish you were here to enjoy these goodies. Maybe something for our next campaign, Eat Healthy, Prevent Cancer.
This is really good.
I'm really happy today. 10 years back, when we started Hope Circle, a volunteer organization to help cancer patients and their families, I wasn't sure how far we could go to help these patients. Have a look at this. 10,000 families we have touched.
I have been encouraged by the stories from the community. I have been an oncologist for the last 40 years, and I can see the change made by the Hope Circle.
Sir, you have been our strongest voice, especially now with Dr. Geeta joining us for our cancer policy team. I'm sure we're going to see miracles. And with Johnson sir also here with us, who himself is a living miracle.
Thank you, Dr. Jomsi. Even in my wildest dream, I never thought I could get cancer. Thank God I have survived it. With the support of the Hope Circle, I'm sure I will strive to do better.
This is Aarti, Mr. Verma's daughter, who has been fighting with cancer for a couple of years.
Thank you. I really want to thank Varun Bhaiya. I thought I would have to quit college at this stage. My father's bills were piling up. But Varun Bhaiya helped us sort out the insurance. I'm really grateful to you and the entire Hope Circle community for supporting us through these tough times.
Varun has broken the cycle. History won't repeat this time.
Varun, please don't do this now.
We have worked so hard to get in this med school. You can't just quit now.
I really can't afford it anymore.
I am here for you.
I know. I'm not quitting on life, Ben. My father is undergoing treatment for severe depression and he can't work anymore. Just didn't work out the way I planned. I have to do what I must. Life doesn't make sense today, but I hope someday it will.
I never truly understood Varun's decision. Perhaps it was his loss which made me start the Hope Circle. Here, in sharing our pain, many have found strength to survive and hope in darkness.
The cost of my treatment is breaking us. Vinay is borrowing from everyone. How can we support our little Varun's dream of becoming a doctor? Is my life even worth it?
It'll always be worth it, Ma. This fight is for you.
That was a wonderful film. Financial toxicity still is a very hardship, and the hardships faced by the patients afflicted with cancer is a big burden, and hope we can able to make changes in their lives as a collective initiatives. Now we have a short program. We'll be issuing the certificates of the BFIT challenge.
ഗുഡ് മോർണിംഗ്. താങ്ക് യു ഓൾ. നമ്മൾ ഡിസംബർ 1 മുതൽ ജനുവരി 19 വരെ 50 ദിവസമായിട്ട് ബിഫിറ്റ് ചലഞ്ച് ഇവിടെ അറേഞ്ച് ചെയ്തിരുന്നു. ഓൾമോസ്റ്റ് 110 പേഴ്സൺസ് ആണ് ചലഞ്ചിൽ ജോയിൻ ചെയ്യാൻ വേണ്ടി രജിസ്റ്റർ ചെയ്തത്. ചലഞ്ചിൽ കംപ്ലീറ്റ് ചെയ്തത് അച്ചീവേഴ്സ് ആയിട്ടുള്ളത് 33 പേരാണ്. അപ്പോൾ അന്ന് നമ്മൾ പറഞ്ഞിരുന്നു അതിൽ അച്ചീവേഴ്സിന് എല്ലാവർക്കും നമ്മളൊരു ലക്കി ഡ്രോ കാണും, കൂടാതെ സർട്ടിഫിക്കറ്റ്സും മെഡലും ഉണ്ടെന്ന്. അപ്പം സമയം കളയാതെ തന്നെ നമ്മൾ അതിലേക്ക് കടക്കുകയാണ്. ഓക്കെ, അപ്പം ആദ്യമായിട്ട് സർട്ടിഫിക്കറ്റും നമ്മുടെ മെഡൽസ് ബാഡ്ജസും അങ്ങ് വിതരണം ചെയ്യുകയാണ്. അതിനകത്ത് വിന്നർ അല്ലെ അങ്ങനെയുള്ള ഒരു കാര്യങ്ങളൊന്നും നമ്മളില്ല. അച്ചീവ് ചെയ്ത എല്ലാവർക്കും നമ്മൾ ഇവിടെ സർട്ടിഫിക്കറ്റ് കൊടുക്കുന്നുണ്ട്. അപ്പം ആൽഫബറ്റിക് ഓർഡറിൽ തന്നെയാണ് വിളിക്കുന്നവർ. ദയവ് ചെയ്തുണ്ടെങ്കിൽ പെട്ടെന്ന് തന്നെ വന്ന് കളക്ട് ചെയ്യണമെന്ന് അപേക്ഷിക്കുന്നു. എബിൻ എബ്രഹാം ഇപ്പോൾ എത്തിയിട്ടില്ല. ആദിത്യ ബോസ് വന്നിട്ടില്ല. മിസ്റ്റർ ആൽഡ്രിൻ അലക്സ് ഓക്കെ, സ്റ്റുഡൻ്റാണ്. മിസ്റ്റർ അമൃത് ജേക്കബ്, congrats. Ms. Anaina Ruth Rajan. Sorry. Mr. Ashik Matthew. Mr. Ashwin Surendran. Ms. Beena Nicolavas. Mr. Deebu Shibu Jacob. ദീപു ആണ് ഇത്രയും സ്റ്റുഡൻസിനെയൊക്കെ കയറ്റി പാർട്ടിസിപ്പേറ്റ് ചെയ്യിപ്പിച്ചത്. താങ്ക് യു. ദീപു സൈക്ലിങ്ങും ഉണ്ട്, റണ്ണിങ്ങും ഉണ്ട്. ഡോക്ടർ ടോണി മാത്യു. മിസ് എൽസ അലക്സാണ്ടർ. Joseph M. Matthew. Mr. Labby Abraham. Dr. Liaquat Rubesh Johnson. Champion. Dr. Maxwin Matthew. Ms. Ninu Maria Wilson. Nidhi Matthew. Pooja Krishna. Rojin Matthew. Shijil Joseph. തീർച്ചയായിട്ടും ഇതിനകത്ത് ഒന്ന് രണ്ട് കാര്യങ്ങൾ കുറച്ച് പേരൊക്കെ ചലഞ്ച് കഴിഞ്ഞപ്പോൾ നിർത്തി. തീർച്ചയായിട്ടും ഇത് കണ്ടിന്യൂ ചെയ്ത് തന്നെ പോകണം. പ്രൈസ് എന്നുള്ളത് കൂടി. മിസ്റ്റർ തോമസ് സി ചെറിയാൻ. ഷിജിൽ വിനീഷ് ലാൽ. മിസ്റ്റർ വിപിൻ ടി വർഗീസ്. ഡോക്ടർ ദീപക് അരവിന്ദ്. ഇതെല്ലാം തുടങ്ങാനുള്ള ഇൻസ്പിറേഷനാണ് സാറ്. ഡോക്ടർ ജെപ്സി ഫിലിപ്പ്. ദീപു ഷിബു സൈക്ലിംഗ്. ഡോക്ടർ ഏക്നാഥ്. ഗോഡ്ലി മാത്യു. ജെഫിൻ ജേക്കബ് മാത്യു. റോണി കെ തോമസ്. റോസി മാച്ചൽ. തൊട്ടടുത്ത് വന്നിട്ടാണ് വീണുപോയത്. 427. ടീന. ഇനി ലക്കി ഡ്രോ ആണ്. പെട്ടെന്ന് തന്നെ തീർക്കുവാണ്. വാ, എന്ത് ചെയ്യാം പേപ്പർ. ഓക്കെ, ഫസ്റ്റ് നമ്മൾ ബോട്ട് സ്റ്റോൺ യുനോ ബ്ലൂടൂത്ത് സ്പീക്കറാണ്. എടുത്തു. എല്ലാവരുടെയും പേര് ഇതിനകത്ത് ഇട്ടിട്ടുണ്ട്. അത് തന്നെ. അല്ല, പങ്കെടുത്തില്ല, അച്ചീവേഴ്സിൻ്റെ ഉള്ളൂ. പറഞ്ഞു. സീരിയൽ നമ്പർ 4
Amrit Jacob.
ബോട്ട് ലൂണാർ ഡിസ്കവറി സ്മാർട്ട് വാച്ച് ആണ് അടുത്തത്. വാ ഏബിൾ സർ. നോക്കാതെ എടുത്തു.
Serial number 3, Mr. Aldrin Alex.
നെക്സ്റ്റ് ബോട്ട് വേവ് ഫോൾസ് 3 ഒരു സ്മാർട്ട് വാച്ച് ആണ്. അച്ഛൻ
Serial number 2, Mr. Aditya Bose.
അടുത്തത് 43 ഇഞ്ച് സ്മാർട്ട് ടി വി ആണ്. ഓക്കെ ആരാ റോസിമ.
Serial number 23, Mr. Vinish Lal.
ആ രണ്ടെണ്ണം ഐ ടി കിട്ടത് എല്ലാവരും പേര് വേണേ നോക്കാം കേട്ടോ. ഇനി അടുത്തത് നെല്ലിയാമ്പതിയിലുള്ള തമ്പുരാൻകാട് റിസോർട്ടിൽ ഒരു 1 night 1 day ഫാമിലിക്കുള്ള പ്രീമിയം സ്റ്റേ ആണ്. ഓക്കെ, ലാസ്റ്റ് ആൻഡ് ഫൈനൽ ഡ്രോ ആണ്.
Serial number 10, Tony Matthew, Dr. Tony sir.
അതപ്പം പ്രൈസ് ആയിട്ടല്ല, തീർച്ചയായിട്ടും അത് അറേഞ്ച് ചെയ്തിട്ട് സാറിനെ കോൺടാക്ട് ചെയ്യുന്നതായിരിക്കും. ഓക്കെ ഓക്കെ, താങ്ക് യു ഓൾ. താങ്ക് യു സോ മച്ച്. വെച്ചായിരുന്നു തിരിച്ചങ്ങ് വെച്ചു.